Hepatic inflammation can be caused by viral infection, autoimmune hepatitis, toxic exposure, including alcohol and drugs, or metabolic. This is a good summary slide showing all the viral hepatitises. Notice at the top you have hepatitis A and hepatitis E at the bottom. These are usually mild, benign hepatitises, and these are self-limited. These do not cause chronic hepatitis. B and C, however, can result in chronic hepatitis. Notice how the chronic hepatitises can result in hepatocellular carcinoma. On the right, you see that hepatitis C becomes chronic in 85% of the cases. In hepatitis B, you can also get a chronic hepatitis, but this is a little more rare than with hepatitis C. Notice that the risk factors are about the same as well in the chronic hepatitis versus the acute hepatitis. In the acute hepatitis, the risk factors are fecal-oral transmission. But disease manifestations are due to viral infection of hepatocytes and necrosis. This also causes a brisk inflammatory response, which then results in cell death. The loss of function of the hepatocytes is what causes the increase in bilirubin and jaundice. Here you see a pathologic slide showing hepatitis B infected hepatocytes. Notice the ground glass appearance in the slide. Here you can also see a councilman body, which is also seen in acute viral hepatitis. These are non-specific findings, but can be seen in acute. In chronic hepatitis, inflammation is usually limited to the portal tract and the limiting plate. Notice all the purple lymphocytes here, seen in the viral hepatitis usually has three phases. There's a prodrome, in which patients complain of fever, hepatomegaly, or increasing LFTs, which are seen on blood tests. Then there's the icteric phase, which is characterized by the onset of resolution. This is when the patients have jaundice, but usually are feeling better with respect to the prodrome. And then finally you have the recovery, which is the resolving of the jaundice and the LFTs. Other symptoms that you can see during the prodrome include nausea, vomiting, anorexia, malaise, weakness, and oftentimes diarrhea. Hypermobility. Here's a slide that shows the time course of viral hepatitis. Notice that on the left you have the incubation period, which is usually the asymptomatic period. Then you have the onset of symptoms, and then you notice the increase in the bilirubin, which is the jaundice phase. Notice also that as the symptoms viral hepatitis is usually characterized by serologies. In the case of hepatitis A and hepatitis E, you have IgM and IgG. The IgM usually indicates an acute infection versus the IgG, which shows past exposure. Hepatitis C and hepatitis D also have antibodies associated with them, which indicate active infection. Hepatitis B can usually be confusing, but the next slide should help make that easier. In hepatitis B, you have hepatitis B surface antigen and the surface antibody. You also have the IgM and the IgG, which also against the core antigen, which indicate current or past exposure. The envelope antigen is also indicative of. This slide shows the various questions you'll be asked on the board. Notice that the characteristics of the enzymes. In acute infection, you usually have a positive surface antigen, a positive E antigen, which indicates active viral replication, an IgM against the core, which is acute, but you haven't had time to develop the IgG against the core, or time to develop the anti-hepatitis B surface antibody. In the window period, which is the most commonly asked question, this is defined as an absence of the hepatitis B surface antigen and an absence of the hepatitis B surface antibody. So it is the hiding out phase during which the only thing that can be found is the antibody against the core antibody. That's the IgM. In chronic infection, you can see a positive hepatitis B surface antigen or a positive hepatitis B core antibody. In the recovery period, you usually only see the antibodies against the core or the surface. In which of the following do you see chronic hepatitis? Hepatitis A, B, C, D, or co-infection with B and D? The answer here is hepatitis C. This is the one that results in chronic hepatitis in 85% of the time. If you chose hepatitis B, that is also correct. However, this is not the most likely. Remember that hepatitis B, autoimmune hepatitis, is a disease in which there are antibodies against the liver. It's associated with other autoimmune conditions such as rheumatoid arthritis, thyroiditis, Sjogren's disease, or ulcerative colitis. It's also associated with HLA-B8 and HLA-DRW3. Patients with these diseases, it's usually indistinguishable from chronic viral hepatitis, in which you get an increase in the AST and the ALT. The course is variable from indolent to severe or progressive, resulting in cirrhosis. 80% of these patients usually have other autoantibodies detected in their serum, including ANA, SMA, AMA, and LKM1. The disease responds dramatically to immunosuppression with respect to steroids. Toxic hepatitis has many causes, including alcohol, which is usually the most common, aspirin, as in the case of children, or drugs, which is a very large category, including isoniazid, Tylenol, amiodarone, halfane. Alcoholic cirrhosis usually has 3 stages. There is the hepatic steatosis phase, which is the fatty changes, in which alcohol is metabolized to triacylglycerol. The liver is enlarged and may be tender, and the macroscopic analysis shows fat droplets in the cells. This disease is reversible with abstinence. Then you get the alcoholic. This slide shows hepatic steatosis. Notice the white globules in the picture. This is where the fat usually is, which is taken out during the cell processing period. So it shows up as white. Hepatic steatosis, in other words, fatty change. Alcoholic hepatitis and alcoholic cirrhosis, again, are the 3 manifestations. But now we'll focus on the alcoholic hepatitis. This is an acute illness caused by acetaldehyde following binge drinking. It's clinically variable from asymptomatic to fulminant hepatitis and following liver failure. Microscopically, you can see hepatocyte swelling. Here you see a picture of hyaline-Mallory bodies. These are the bright pink areas here on the slide. This is damaged intermediate filaments. Alcoholic cirrhosis usually develops in 15% of alcoholics. It's characterized by a micronodular cirrhosis. Graves syndrome, the etiology is unknown, but it's usually found in children with viral illnesses treated with aspirin. So remember, don't give a baby aspirin. Causes include hepatic steatosis or fatty change, which then results in frank cirrhosis and cerebral edema, encephalopathy. 25% of patients. Now we'll talk about the metabolic liver diseases, which include Wilson's disease, hemochromatosis, and alpha-1 antitrypsin disease. Wilson's disease is an autosomal recessive disease. It's characterized by a defect in hepatic copper transport and decreased ceruloplasmin production, which is the copper binding protein. This results in excess copper deposition throughout the body. This is also known as the neuropsychiatric hepatic disease. The accumulation of free copper is toxic in many tissues, including the liver and the brain. In the liver, it causes an acute hepatitis progressing to cirrhosis, and in the brain, in particular. Here you see a slide showing fatty changes and copper accumulation. Notice the copper here, which is bronze appearing. In Wilson's disease, you get the predominant signs and symptoms are cirrhosis, as well as movement disorders, such as Parkinson's disease associated with psychiatric manifestations. It's diagnosed by a low ceruloplasmin. A liver biopsy can also show an increased tissue copper and cirrhosis. This slide shows what Kaiser-Fleischer rings look like. Notice at the edges of the cornea, you see the brown pigmentation. This brown-bronze pigmentation is the copper deposition. Hemochromatosis is a completely different disorder characterized by an increase in iron. In this disorder, you see increased blood and tissue iron levels. It's hereditary, mostly autosomal recessive mutation, causing increase in intestinal iron absorption. It's more common in males than in females, and it's usually found in those of Northern European descent. It can also be an acquired disorder in which patients get chronic transfusion therapy for anemia. Remember that hemochromatosis results in toxic iron deposits in multiple organs, including the liver, the heart, the pancreas, skin, and gonads. Deposition in these organs results in failure of these organs. In the heart, it causes congestive heart failure. In the pancreas, it causes acquired diabetes mellitus. And in the skin can result in bronze pigmentation, or known as bronze diabetes. In the gonads, it can result in gonad failure, including hypogonadism. And in the liver, of course, it can cause micronodular cirrhosis. Remember, the cirrhosis is a significant risk factor for hepatocellular carcinoma. And in the past, hemochromatosis. Here you see a pathologic slide showing the increase in tissue iron. Notice all the bright blue spots on. Alpha-1 antitrypsin deficiency is characterized by a mutation in the alpha-1 antitrypsin gene. The PIM is normal, PIS is noted by a mild decrease in activity, and the PIZ shows markedly decreased activity. So those patients who are homozygous in PIZ, alpha-1 antitrypsin functions as a protease inhibitor. regulating the function of other proteases, particularly the neutrophil elastase in the lungs, but also trypsin, chymotrypsin, and bacterial proteases. Normal inflammation causes considerable damage to normal tissues in the absence of this regulatory function. In other words, when this regulatory enzyme is deficient, the inflammation results, and the inflammation results in tissue destruction and lung injury and cirrhosis. So these patients usually develop a micronodular cirrhosis and are at increased risk for hepatocellular carcinoma as well. A 55-year-old male has icterus and increasing abdominal girth. Serum lab findings are a bilirubin of 4.2, a direct bilirubin of 4.2, alkaline phosphatase of 995, an AST of 300, an ALT of 158, a total protein of 6.4, an albumin of 2.2. The most likely diagnosis is choledocholithiasis, acute hepatitis C, acute hepatitis B, alcoholic liver disease, or Wilson's disease. This patient has findings consistent with cirrhosis. Notice that they tip you off with the icterus or the jaundice, and they increase the abdominal girth, which most likely indicates ascites. Notice here also that the albumin is low, 2.2, and the INR is high, or the PT being 18, which is high. This patient likely has alcoholic liver disease. Notice that the AST to ALT ratio is roughly 2 to 1, and notice that the AST is not greater than 300.